We are the Association for Child and Adolescent Mental Health, or ACAM for short, and this is ACAM Learn.
Hello, and welcome to the Mind the Kids podcast. I'm Clara Faria. I am a child and adolescent psychiatrist in training based here at the University of Cambridge and also a research scientist. And today I have the honor of receiving in our podcast Tom Osborne. Tom is a community mobilizer, entrepreneur, and also a research scientist. He is the founder and CEO of the Shamiri Institute, which is a grassroots pioneer mental health organization in Kenya, where he is leading some really important changes in local mental health. So welcome, Tom. Thank you so much for being here with us.
No, thank you so much for having me, Clara, and I'm really excited for this conversation with you today.
Yes, me too. So I think I wanted to start by the beginning of your academic journey. So I know you did your undergraduate at Harvard, and from then you basically went on this fantastic journey of founding Shamiri and having a real concrete impact in mental health of children and people in Kenya. So I suppose I wanted to ask you, like, how did you have that idea? Is it something that was brewing since your undergraduate in Harvard? Yeah, and whatever else you want to share with us as well.
Yes, that's kind of precisely where it all began, was, during my undergrad at Harvard. But just to give some background context, I was born and raised in Kenya, went through the public school system here until I graduated from high school. So fun fact, when I was in high school, I actually didn't want to go to university. I saw myself, as an entrepreneur working with local communities, etc. And so actually my first venture was in the climate change space, so growing up in rural Kenya, we were using a lot of firewood and charcoal to cook, which was not only just bad for the environment, but also for people's lungs. So my mom had this really bad respiratory tract infection as a consequence of this. I wanted to do something in the space. And so for 3 years after high school, I ran this company, which basically was converting sugarcane waste into clean burning fuel for rural communities. And then I was pretty lucky at the end of that to get a full ride to go to Harvard for undergrad. And initially I thought I was going to study something around energy systems and economics. And in fact, that's what I was studying until my second year, where I had to take a intro to psychology class as a required class. And this class, kind of had this really life-changing experience for me, because for the first time I was able to see a lot of experiences that I had had from a mental health and well-being, perspective, kind of realizing that not just myself, but also people close to me were either struggling with depression, anxiety, and so that really sparked this curiosity about psychology and mental health in particular, that led me to switch my major to psychology, but to also join a laboratory called the Youth Mental Health Laboratory at Harvard. And it was at this laboratory where my future career path and the work that we were doing at Shamiri will eventually end up being formed. So to be more, detailed, the crux of the work that they're doing in this laboratory was trying to develop interventions for youth mental health, and folks like Dr. Jessica Schleider at that time was a graduate student of the lab, and there's so many other folks like her who are, kind of doing all of this intervention stuff, and then they're also doing a lot of meta-analysis work and trying to, really figure this out. Then, the curiosity for me was both on the scientific part, but more importantly, what I did see as an opportunity was that a lot of these really cool interventions were, in my opinion, dying in academic journals. So every year they publish 2 or 3 big RCTs in these big journals. And then I was like, okay, why are the researchers then, kind of moving on to do the next research project? Why is, kind of no one really thinking about how can we take this research and try to, build infrastructure that could help us to scale it, right? And so that allowed me to really find my path at the intersection of working with researchers who are developing these new cutting edge interventions, but also taking advantage of my community mobilizing skills and my passion for social entrepreneurship and social innovation to try and tackle this from a scaling perspective, right? So that then informed the work that we do at Shamiri. So Shamiri is a Kiswahili word for thrive. And so basically our mission is to bring at scale this type of brief evidence-based interventions that have been shown to be effective, but to be able to then deploy them at communities, and especially low resource communities at scale in a really data-driven and data-informed way.
Yeah, and that's really amazing. Before moving the conversation, oh my God, I just have to say this is so cool that Jessica Schleider was a graduate student at the time, because I was actually like, when I was reading to do this podcast, this interview with you, and when I was reading about, all about Shamiri and the Shamiri late pass and intervention and all of that, I was like, oh my God, so much of this like relates to Jessica Schleider's work. I mean, the efforts of like, obviously it's all your original fantastic work, but like all the efforts of, like a simple intervention that can be scalable, because now she's doing a lot of around single session interventions in, I think, Northwestern. And it's so cool that it worked together at some point. And it's really cool to see like how those trajectories intersect and kind of like, yeah, that's really amazing. So well, move on with the conversation. As you said, you saw that lots of people around you were struggling with depression, anxiety, and other mental health conditions. And as we know, well, I think there is sufficient evidence, at least here in the UK, to point out to the fact that the prevalence of mental health conditions in children and young people is increasing, and not only like clinical level diagnosis, but also like what we call subthreshold difficulties. So young people are struggling more. And at least here, one of the major barriers that we have in our health service at the moment is super stretched. And whenever we talk about expanding capacity, a problem that people point out often is the cost of therapy and how it's expensive to train psychologists. All of this context is to say that I thought it was a really fantastic and genius way that you came up with in Shamiri of doing the peer-to-peer intervention and how you were able to scale that up. So I was going to ask you more about that. Like, how did you come up with this model, like the model that is the base of the Shamiri like person intervention? And was it something that you had seen working before?
Yeah, I think there's a coming together of a few different ideas which were intertwined from my previous experience. So when I was in this lab, what became pretty clear pretty quickly was that there were these brief interventions that could have large effects, right? So the work of Jessica Schleider and Joan Wise, who was the PI, who's still the PI in the lab, was really trying to document that you could get similar effects with simple interventions like growth mindset, gratitude, etc. But then also that you didn't need more than 4 or 5 sessions of just one-on-one therapy, right? So that was one school of thought that I was really impressed upon by John Wise, Jessica, and the many other great people who were in the lab at this time trying to really pioneer this work. The second came from my experience, growing up in Kenya. And growing up in Kenya, we had really experienced a lot of success with these folks called community health workers. And the idea of community health workers from the primary health perspective was that these were lay people who will go door to door across mostly rural homes, and be able to do, kind of like basic screenings for things like malaria, etc., basic, kind of administration of vaccines, and basic meds like malaria helped improve health outcomes, quite significantly. So at least in a similar context in healthcare where we still had a paucity of expert providers, this community health worker model had proven really inspirational in terms of doing the last mile health delivery. And at that time, Professor Vikram Patel, I think he was still based in India at that point, was also trying to experiment with variations of this for mental health, right? But I was convinced, kind of pretty quickly that, okay, like if they were able to have all of this success in primary health, we could also be able to do it with the mental health space. And the third idea was the idea of like community. And so basically that came from starting, kind of some of the pioneers of more formal mental health in Kenya, including one guy we would highly recommend for the listeners to check out. He's a guy called Thomas Lambo, and he was the first psychiatrist in Nigeria, I think in 1950s. He was only one psychiatry for the whole country, and he pretty much realized that a lot of this, traditional methods that had been taught couldn't really meet the needs. And so what he did is he built a village hospital model where he basically turned resources within the village, like schools, churches, even just like trees, into centers where people could do group, etc. And so basically, the thesis of Shamiri was there a way to marry all of these three ideas, from these effective, simple single sessions that could be destigmatizing and less stigmatizing, to task shifting, to the equivalent of community health workers, to then embedding, all of his work within communities. So what ended up being our model was that we combined really three single session interventions into a much more longer 4-week intervention that taught growth mindset, attitude, and value affirmations. We combined them into, kind of like a protocol. We decided to train recent high school graduates, 18 to 22-year-old, as lay providers or version of community health workers in this context. And then we decided to make this work be embedded within schools as a group-based model where people go through this content together.
That's so cool because, like, just out of anecdotal experience as well, like, so in Brazil, like, have you been to Brazil? I think you were in Yakapap, weren't you? Yeah, that's so cool. So, well, I'm not sure if you've seen that because that, like, it's a bit segregated, but like, sadly in Brazil we have like lots of social inequality. So we will have these communities called favelas, which are like embedded within the city, and like the most successful health intervention that our primary care system has implemented in favelas are the community healthcare workers, which will be someone in the community who has received some basic health skills training, but they're going to do precisely what the community healthcare workers in rural Kenya you were telling did. Like, they're going to go to people's houses, they're going to check for vaccinations, they're going to do like basic screenings to see if, oh, are you taking your medications for, like high blood pressure and that kind of thing, and they will be much more accepted than, like, I worked in one of those communities for like a year, and they would be much more, obviously if it was something that required more medical attention, we would go, and if the patient couldn't move out of their homes, we would go there and we would do like a home visit, but they were much more accepted than us, and it would often be that they would be the first point of contact and they would go in first and then they would report, because it's just like community health workers is just something so fantastic and so amazing, and as you said, it's a way that we can scale and reach much more people. So it's really fantastic that you combined those really three great ideas to create the Shamiri layperson intervention. And I will link in the podcast because the Shamiri lay intervention was already tested and published in JAMA and in the BMJ, and there are several articles that I know you've published around it. We will make sure that they are linked for people who want to check them out as well. But it is really fantastic. Also, as you said, lots of countries, in Brazil, there is also a shortage. Lots of countries have even less personnel. And as you said, there is a huge mental health need to be filled. And on that note, what I wanted to ask you is that I think Shamiri has, in a certain way, helped a lot fill this gap for mental health care in Kenya, in youth in Kenya. And looking at all that you've achieved in the past years, what do you think are the main challenges that, like, Kenyan mental health youth still faces? And what are the challenges that you're still looking to conquer?
Yeah, thanks also for sharing the story you shared. I think that also just points out to, what I've been trying to emphasize, and I think there's a lot of momentum around more like South-South collaboration, right? Because, a lot of these challenges you're facing is similar, at least at an abstract level. And I think a lot of these solutions and ideas, can be quite easily cross-planted, across these different settings. With regards to the challenges that the young people in Kenya are facing, obviously it's evolving, So when we started doing this work in 2018, 2019, and actually prior to COVID, most of the issues were around just societal, pressure, which was a really big risk factor for a lot of mental health problems. Just to paint a picture, for most kids in Kenya, education is always seen as the only pathway, out of poverty. And so you have your parents, your siblings, your community are all really, kind of like invested in the education of one person, right? And so you're kind of almost seen to some extent as like a get out of poverty card, if I may use that phrase. And then so this, really puts a lot of like pressure on young people. And then the boarding school, so we have a public boarding school system for the majority. So where 80% of adolescents go into these public schools. There's also like, pretty crowded, it's pretty intense. And so that, kind of pressure cook environment was pretty, it was like a really big issue when when you're starting to do this, right? And so what we realized actually as we were doing this work initially, that even interventions around, social skills, life skills, study skills were also quite important and relevant, kind of in this context. And of course, there are, the environmental factors associated, with things like low resources that, kind of come into play. But since COVID, 19, in addition to that, there has been an evolution in the mental health needs and the associated, kind of like triggers around them. I think a few things which are emerging, for example, is just digital spaces, social media, is kind of starting to become a thing. In the context of Kenya, we've also had issues around political instability, famine, it's sort of like emerging stresses, which are increasingly becoming an issue and which are increasingly making it, kind of difficult for young people as they're trying to navigate this. We're having, kind of all of these emerging stresses which are contributing to mental health. And finally, from the perspective of the work that we have done at Shamiri, we are facing, two challenges as we're trying to scale. So the first is who is going to pay for this at scale, right? Can we get the government to pay? But governments are generally broke and have other competing health priorities. And can we get parents to pay? Parents also generally broken have other priorities because like we cannot be able to scale through philanthropy alone. So at some point we need to find ways to scale this bigger and better with more sustainable pay. And similarly, as Shamiri, we can't scale across the whole country. So at some point we need to be able to bring on board other players like local organizations to also like replicate our model.
That sounds like a big challenge ahead. I have all my fingers crossed, and I think like you're 100% right. And I think like in a very different scale, and again a very different setting. And as you also said, I think the South faces unique challenges that usually the more developed nations do face, but face in a different measure with different resources. So here in the UK, for example, here we also are in the middle of a mental health crisis. So our services are super stretched. Like, for example, we have a 2 to 3 year waiting list for CAMS appointments, which is the child and adolescent psychiatry services. And obviously I know that in lots of places there isn't even a waiting list because there isn't an organized service. So given those, considering those proportions, but then I see a similar scenario the one you described, where we have lots of mental health charities here that are doing a fantastic job, and lots of them are very serious, like ACAM, and have evidence-based work and all that. But there comes a point where, as you said, from a certain point onwards, you need either government or private money, but the money needs to come from somewhere. Philanthropy alone cannot do it. So it's really interesting to see the challenges you're facing at the moment, and I do hope that you guys are able to kind of scale more and more and get that finance. I also think it's interesting. So you've mentioned self collaborations, and something I've been observing as well is the role of global philanthropic institutions. What do you think? Because I know that you've been in both places, right? You've been in the US, you're now based in Kenya. How do you see those relationships and collaboration?
Yeah, so my belief is eventually those who are closest to the problem are closest to the solution, right? And as much as we need to and we must facilitate collaboration throughout the board, I think this has to be done in a way that really empowers and centers the solution around those who are actually, closest to the problem, right? So in this perspective, it will be great to collaborate with organizations, for example, in Brazil, who are doing similar work, right? And so my belief, especially when it comes to North-South collaboration, is often what happens is folks who write the checks sometimes confuse that or conflate that with knowing what works best for everyone and in every context. And that is very erroneous in my, kind of opinion, right? And so the perspective that I am taking is that in this type of collaborations, that work should be geared towards, really amplifying and empowering proximate solutions. And I think increasingly we're starting to see, hopefully it doesn't, we've had this 2025 has been a really difficult challenge for those of us who work in the mental health space from a funding perspective. Immediately post-COVID, I think one of the silver linings from the pandemic was it really brought mental health to the core of everyone's thinking and really, unlocked a lot of like funding around this. And this, has been really instrumental for organizations like Shamiri to really pick up and to really scale. But now we're starting to see, at least from multilateral funders, for example, USAID is now dead. Other development agencies like the UK, Nordic countries, France, etc., are slowly scaling down their portfolios, right? And the amount of funding that they're giving. And so there's a big impetus now for more locally sustainable revenue sources. And so how I see it is this funding unlocks the initial innovation and unlocks the initial experimenting and creates an environment that allows us to be able to take risks and build off those risks. But eventually we will need to find ways to get, in my context, the Kenyan government, Kenyan school districts, individual schools, and different parents to also see the value proposition of what we're doing and really be able to support that, right? So those are really key and crucial for me, right? But collaboration remains key. And I think what we can do now is share best knowledge and best ideas. Like we have been training lay providers, and if folks want to do that in Brazil, there is no need of reinventing the wheel. They can build off the work that we do, refine it and modify it to make sense in that context, and vice versa. So I do think that is what the crux of the super strong collaboration that can turbocharge this movement is going to be moving away from silos and creating learning communities that can empower us to build these systems in a proximate way that works for the context that we work with, but is built on years of evidence and best practices and shared learnings.
100%. And as you said, like context is everything, right? Like, and I think it needs to be context specific. And one of the points you made, which I agree a lot with, is that oftentimes like the funding agency or the group who's bringing in the funding, especially when we think about North-South collaborations, definitely can happen. But we are implementing our intervention in your setting, and then it's an intervention that comes pre-made, and then it doesn't work because there are like several challenges that are context specific. And speaking of challenges, you mentioned the COVID pandemic, and one of, I think, the effects the COVID pandemic had globally was really putting youth mental health in the agenda. But I think we were affected differently. When I say we, I mean like each country had its unique challenges, and like likewise youth mental health organizations had their unique challenges. So I wanted to ask you about how was that for Shamiri, and this is a more challenges question, like what was the biggest challenge the organization faced so far aside from funding?
Yeah. So I put them in a few different buckets. So I think the first bucket is translating research into practice. And so what I mean by this is a lot of the research that we were building on, a lot of the research that we were building on was really done in super controlled environment, where you're really trying to maximize for internal validity within the study design that you did, right? And so a lot of variables are controlled, etc. But once you move outside of that context, and especially as you're beginning to scale and you're operating in implementation real world context, you do not have the ability to pretty much be able to have as much control, so things like fidelity, it becomes super crucial and super important, right? And how do you translate and obtain, kind of like that fidelity, kind of as you're scaling, that comes with issues of like quality control, etc. So the first big challenge is just from a technical perspective, how do you simplify kind of evidence-based protocol into a model that can be replicated at scale with as close to similar impact, etc. Right. So that becomes one of the first, kind of like big challenge that we face. But then the second one, which a lot of people also face, is with regards to basically just how you then build a team that is very complementary. And so, for example, in our context at Shamir, we had to be able to do three things effectively. So one is implementation. So like on the clinical side, be able to technically implement the protocols and the models at scale. Then the second part of it is we also have to be able to collect data and be able to do research and to be able to allow this research to inform, like the work that we are doing, kind of effectively, and then the third is from a product perspective. So how do you turn the research and the implementation into a product that users can be able to interact with? Like, how do people sign up? How do they book sessions? How do they follow up? How do they connect to their data? And what we realize is often this requires different people with different skill sets who often don't work together. And so then you need to build the team, kind of build that equal, system, kind of around that to make sure that it works. And that, is a pretty big part, like just building, kind of that team. And then finally, the other challenge you face is how to sell this. And this becomes especially important in this context where you realize that the different stakeholders you're trying to sell to who often want different things. In the context of Kenya where we work, most of our work is school-based. We're working with students. Yes, a student might be depressed, but the outcome that they're interested in is different from what the parent is interested in or what the school is interested in. The school, for example, cares about school climate, want them to stay at school and to graduate and to get better grades. The student maybe just cares about, belonging and interpersonal relationships, and then maybe not as much about staying in school as a schoolmate wants to care. And what we realized, which was for us shocking, was at least in Kenya, for all of these constituents, they didn't really care about reductions in depression and anxiety, at least as measured by DSM-5 based tools like the PhD and the GAD, because we just didn't really understand it, right? They're like, okay, so if I had elevated symptoms and now I don't have elevated symptoms, what does that really mean? What is the consequence of that, right? And so finding ways to articulate that consequence became very important for us, because from a research perspective, what we really cared about was effect sizes, reduction in depression, so the effect sizes, how long it lasts. And it makes a lot of sense from the perspective of a researcher or a clinician, but from the perspective of a client, what does that effect size of D equal 0.3 really mean? Like they can't really conceptualize that, right? They want us to be able to find ways to articulate this and ways that resonate and make sense to what they're actually really going through. And so what we end up doing in our context in this regard was being able to, we call it like a Thrive Index. So basically we're tapping into things which matter to all of these constituents, from mental health, reduction outcomes, to school climate, interpersonal relationship, academic outcomes and achievement, and livelihood, which also all make sense because they're all, different parts of the story of mental health. And so moving away from just a purely clinical outlook and presentation to a more thriving and flourishing presentation took us like a couple of years to get to, but was really crucial because once we figured it out in 2021, we were able to rapidly scale from working with about only 3,000 youth per year to 25,000, 100,000, just, like in 2 years, because now it was pretty easy for us to get this buy-in and do it.
Wow. Yeah, it's really interesting. You mentioned the last challenge, the challenge about oftentimes clinicians and researchers using metrics that are not, like, as you said, like we care about the effect size. So we want to see, the reduction in anxiety, depression, but the school doesn't necessarily care for that. And the buy-in of the stakeholders is so important, right? So it is really amazing that like you're able to scale up this much just by looking at like different metrics and by looking at like, and I suppose like here sometimes we do lots of like PPI, we do lots of public and participant involvement groups. And oftentimes, yes, like when you ask the kids what is important for you, they're not going to say my GAD score. They're going to say if I'm doing well in school, if I have friends, if I am going to get into the university I want to get, and all that. And likewise, the school cares about school like retainment and all that. They care less about the metrics we look at. That's super interesting. And I suppose the other thing I wanted to ask you as well is that I know, so it's interesting that in the beginning you mentioned you had some experience with energy systems, and that stemmed from your experience in Kenya, growing up in Kenya, and you saw lots of people using coal and other things like to cook and all that, and that had an impact on you, and that made you look into how to optimize energy systems and all that. And then from that you went to mental health. But now we also have this whole, it's not exactly my area, but I know it's a very pressing and important area in mental health research, which is echo cams and people looking at the impact climate change is having on youth mental health. And I was just wondering if this is something you're also interested in, because I read you have a project on that as well. And if you can tell us a little bit more about it.
Yeah, so we've actually done some very preliminary work just trying to understand the association of like mental health as an emerging stressor. Like climate change as an emerging stressor to mental health in Kenya. Our findings are a little bit interesting in that they are different from the uh, they're different from, kind of some of those that has been coming from the West, right? So what we found in Kenya is people are mostly anxious about the more immediate weather pattern changes. Like last year, for example, we had this intense 1 month flooding, which came up and affected a lot of like people and livelihoods and closed schools. And the year prior, we had like I think a small period of drought, right? So what we found is like this more immediate weather pattern changes, are at the top of folks' minds in Kenya more than the long-term warming temperatures and future challenges around mental health. That's kind of the main difference we found. And then I think also the traditional quote unquote eco anxiety, eco camps is still also not emerging from the data that we are having here. Part of that, part of that also, is informed to some extent by the history of the relationship that people have with nature in Kenya. So, for example, one story I like telling my Euro-American friends is I didn't meet a climate change denier until I went to school in the US, because in Kenya we grew up with the environment being a big part of people's like culture and the idea of like that interconnection between people and nature and need to like preserve and take care of the environment. And so I think I think people are connected to nature in a way that is, to at least up to now, like buffering some of these issues. But what is kind of starting to emerge a lot is how short-term weather changes are affecting people's mental health. But once again, this is an emerging stress, an emerging factor. And obviously, as more data continues to come, we may see how this unfolds. But that's something that we're interested in, and we've been exploring it with a couple of professors in some universities here, University of Nairobi and Aga Khan University, and excited to see kind of where this research unfolds.
I'm really curious to see how it unfolds and what you find in like successive years. Well, Tom, to wrap up, I just wanted to ask you, like, considering all like the enormous work you're doing and all you've achieved so far, what are you most looking forward to achieving with Shamiri Institute? Like, what is, like, if you had to, I mean, I know you work in many different work streams, but if you had to choose like one, your most important work stream for the rest of this year and for next year, like, what would it be?
Yeah, so our goal at Shamiri is to scale, right? So we want to be able to make sure that we can get our intervention or model to as many young people as possible. And our goal is to serve 1 million youth per year by 2028, right? And so that is the work stream where we're putting most of our energy, because basically we're hoping to show not just locally, but also folks in the West that it is possible to deliver evidence-based care at scale at a fraction of the cost, right? If you orient it on communities, if you mobilize all the resources that you have, including lay providers, if you expand the repertoire of interventions that you use to also include briefs, stigma-free, interventions in addition to the more traditional, cognitive-based therapy, for example. So our goal is to be able to scale up to 1 million youth per year. We are at 135 youth now. We're hoping to get this to 200,000 by the end of the year, and then just like build off from there.
Wow, that's really fantastic. And I mean, I'm sure you're gonna do it because like your passion and your determination for it is really impressive. Like, I know you did your undergrad in the US and then you moved back to Kenya to kind of initiated this fantastic grassroots movement that is impacting the lives of so many people. And I suppose there's always for us that like went to do our education somewhere else, but were born somewhere else, there is always a question and a duality of, should I go back? And I just wanted to ask you, like, was that an easy decision for you and for all the young people out there who are wanting to make an impact in mental health and facing that duality? Like, yeah, do you have any advice?
Well, it's not a simple question. I get asked this question a lot, especially when I travel and meet young people who, like you, are either in Europe or in America, kind of for their studies or are in their careers. And I think it eventually becomes to, in my opinion, an intersection of three things. I think the first is um, where you feel most comfortable, like where and I think this changes for people, as you grow, as life happens, etc. The second is the type of work that you want to do, right? So do you want to be a researcher? And if you want to be a researcher, maybe it makes sense to be domiciled in an institution that has access to more like research funding, right? And then the third is the type of impact that you want to see, right? So for me, it became pretty crucial, to when I was kind of like doing all of these things, kind of what came to me was that I felt that Kenya was, kind of where home was. I felt that I didn't really want to be a researcher in the traditional context of working in a lab and just publishing, kind of like papers. What I wanted to do was to work with folks like that and to be able to, translate them, what they're doing into the real world and at scale. And the type of impact that I was desirous of was really being able to build something which could not just scale pretty rapidly, but be also stable and sustainable in the long run, right? And so when I put all of these three things together, it led me to concluding that the best and the easiest way to do this, will be, kind of like moving back to Kenya. But if I was maybe, kind of trying to go the academia route, kind of my decision-making framework might have been different from if I was trying to go the entrepreneurial, building route, right? So my short answer is of course, it depends kind of with everyone, but at least for me, a good guide has been, where do I find home / feel comfortable in? What type of work do I want to do? And what is the impact that I desire to actualize in the world?
That's really good advice, and thank you for sharing that with us. And I think just to add to our listeners who, well, they will probably know anyway, but I think like in a certain way, you have best of both worlds in the sense that, like, obviously, like your work in Kenya is hugely impactful, but like but your work is also respected within the research.
Yeah. So I am based in Kenya. Kenya is home, but we do work closely. We have collaborators around the world. So like CMI, which you've mentioned, different folks in America, in the UK, even Austria, India, etc. So we're always willing to collaborate with people. Our models and methods are open source, open access. We do help folks who want to like experiment and try this around the world to be able to do it. So pretty excited to collaborate and talk to folks from around the world.
On that note, thank you so much for sharing your research and so many precious insights with us today. For more details, you can visit the ACAM website, which is www.acam.org.